Hey everyone, welcome back to our podcast, The Doc Talk. And today we are going to be discussing with you guys why we feel that ADHD in young children is being overdiagnosed. First of all, what is ADHD? ADHD stands for Attention Deficit Hyperactive Disorder. Um, what are some of the symptoms of this and how does it present in young children? You'll often see young children, they have a difficult time sitting still for an extended period of time. They can't pay attention to simple tasks that other people can normally do. They jump from task to task to task. They typically they're disruptive in the class, even in the house. So these are just some of the common symptoms. But we are here to discuss today and talk to you guys all about is that some of these symptoms actually can be normal developmentally in the child. And as we've seen in recent decades, this diagnosis has been on the rise in young children. So, Dr. Hay, what do you think about this discussion?
I agree with you. I think we're definitely overdiagnosing ADHD. I think we're handing the a diagnosis out just way too easily. If we look at numbers alone, right now about 10% of kids between the ages of 6 to 8 are being diagnosed with ADHD. Whereas we know that the prevalence of the disease in society actually is supposed to be it's closer to 5%, right?
That's correct.
So we're almost diagnosing twice the number of kids that should be getting diagnosed. And I think what you said about the certain things being totally normal at that developmental age is probably one of the key reasons, right?
Yeah. One thought that I had was think about children that start the school year towards the end
Mm-hmm.
of their birthdays. I believe that's how it goes, right?
Right.
So those kids are going to be the youngest kids in the class. So when you take that young child and his peers are older, so to an individual, this guy who's much younger can appear inattentive, easily distracted, maybe disrupts the class too, because he's not at that mental level as his older peers are. So that's one example that
Mm-hmm.
comes to mind.
Yeah, which is very true because the kids that are being diagnosed, a larger percentage of them is among the younger cohort. So typically, a school will take, say, for example, all the kids born in 2016 from January to September, and they'll have a cutoff over there. Okay, most schools are much more lenient, in all honesty, and will typically take even the October, November, December borns if the parents feel like they're ready to start school. Okay, however, go forward 2 more years when they're in first grade or second grade, okay? And even though they may be caught up in the educational material, their development is behind, right? Because we know that the brain develops and grows as we age. So if we think about it's a little bit hard for us to conceptualize this for kids around 6, 7 years old, but think about 12 months versus 18 months and think about how much development happens in that period.
Oh, yes, absolutely.
Exactly.
And then that leads me into the second topic is that these children, they often the first signs where they show up is usually in the classroom. The initiation begins usually in the school, where the teacher notices a pattern of distractibility, the child is not paying attention, others are being disrupted. So the atmosphere of the class is disrupted, and then the parents are alerted about what's going on. And now the parents are getting anxious and worried about, oh my God, what's wrong with my child? And then they bring them to us, and then the chief complaint at the visit is rule out ADHD.
Right. So you're right. So most of the time it's a teacher-driven process. Okay. And most of the time, the way that it comes up to the parent is that the child is somehow falling behind. Okay. And I mean, we know as parents, and most parents would agree, if the teacher of your child tells you your kid's falling behind or your kid's not acting appropriately, you're going to get very worried. And if your teacher suggests a diagnosis to you that it could be something like ADHD, you're automatically want to make sure that there's nothing wrong with your child, right? So you take your child to the doctor, but you're already coming there with the notion from the teacher and from yourself that there's something wrong with the child. So there's not what I like to call balanced visits. The parents are usually almost coming in with the expectation that they know what's wrong with the child and the child needs to be medicated. And so there's a certain amount of pressure on you as a doctor to meet that parent's expectation. And it can be very difficult at times to explain to parents that, hey, your 6 year old not wanting to sit on the carpet and read a book for 2 hours is totally normal. That's what the 6 year old is supposed to be doing.
Correct. And in my opinion, some of these issues that we see in this generation, in the years we live now compared to the past, is if you think back to our days. I remember we used to come to the US on summer vacations, and uh, we would be on our bikes from sunrise to sunset.
Hmm.
We'd be active all day long. We weren't, there was no screens, there was no video games.
Hmm.
We were out expending energy. So children have a lot of energy. What do you think when people age are always trying to do? Get that longevity back, that energy back.
Exactly.
Okay, so children have a lot of energy.
Hmm.
And when there's no outlet to release that energy,
Hmm.
it sometimes manifests as these symptoms as well.
Yeah, 100%. They've got to expend it somewhere. So if they're not getting enough opportunity to expend it outdoors, and as we see, education and classrooms have also become more and more rigid with time. There's a lot of structure in the classroom now, and so that expectation that they're able to take all of this energy and hone it towards that exact structure that's expected of them, just like everybody else in the class is doing, or the majority of the class is doing, it's unrealistic and it's unfair.
Now, if you think about it from this different angle, you have a child in a traditional classroom and very disruptive, not paying attention. But if you take this child and transplant this child, what are those school Montessori's?
Montessori's,
If you
yeah.
take this child and transplant this child into a Montessori, um, you will see this child thrive. Now, why would this child thrive at a Montessori?
Because Montessori's are child interest directed, right? So if the child is much more interested and much more competent at, for example, art than they are compared to math, then they shouldn't be learning art and math at the same level, right? So they should be learning at art that's a little bit more advanced, have more opportunity to hone that talent, and learning math at the scale that they're at. In those cases where the child is allowed to do things that interest them more, you see these behaviors improve automatically, and think about that as adults, right? If
Correct.
somebody is making you do something that you're not interested in, you're not going to want to pay attention. So we have kids in an environment where everybody is learning the exact same thing at the exact same pace.
It's very, very regimented.
Yeah,
It's a very cookie cutter model,
yeah,
and children are not that. Children are not that. We all know that. Children are just, they live in their own world. They live their own lives. It's a different world.
yeah. And
And
to
when we
us,
try to assimilate them to our adult standards of regiment and XYZ, they don't have their prefrontal cortex developed to understand that.
and you see, there's two different types of parents that typically present with these kids. There's the parents that really don't want to put their kids on medication, and really what they're looking for is affirmation that, hey, I feel like what my kid is doing is normal. Okay. And to me, those are the easier patients, because in all honesty, I mean, I have a kid and he can't focus for more than 20 minutes. He's 9 years old almost, and he can't focus on for more than 20 minutes at a single task. He has to get up. He likes to move around. And so it would make life almost a lot easier to get him on something that's going to help him hone all that energy into his prefrontal cortex. So there's parents who do not want medications, they're a little bit easier. There's parents who then feel very strongly, and this is not coming from a bad place, it's because they're very concerned about their kids' academic performance usually. And they want to make sure their kid doesn't end up in a position where they're not going to succeed because they didn't treat it a problem that they have. And so those parents really want that medication.
And that's a very valid concern. And that takes us now into our next segment, which is diagnosis. So we're not saying that ADHD does not exist. Of course, it exists. It's a clinical diagnosis. It has a lot of huge ramifications for children and their development. But what we're saying is overdiagnosis and overmedication also is not some benign issue. Long-term risks, long-term psychological damage, some even have dependence issues. So no, this is not a benign medication.
Low
So
appetite, and kids will suddenly start to lose so much weight because most of the stimulant medications that we use for ADHD will obliterate your appetite. So these kids are not eating as much as they need to. Not eating leads to vitamin and mineral deficiencies, which then in turn, quite honestly, could cause neurological and psychological stuff.
so tell us, how do we diagnose ADHD these days?
So the most common way to diagnose ADHD in most places is using something called the Conners forms. The Conners forms is a validated tool, which means that it shows consistent results. And so there's a form that's meant for the teacher, and there's a form that's meant for the parent. And there's a series of questions on the forms that require subjective answers. So, how would you rate a child's ability to do X, Y, Z? Okay. The teacher fills a form out, the parent fills a form out, they bring it to you, you score it, and the score helps you place a child along a probability of what is the likelihood that they could have ADHD.
And then you look at the whole clinical picture,
Hmm.
what the teacher is actually saying, what the parents are noticing.
And what you're seeing.
And what you're seeing
Yep.
in the clinical room is very
Yep.
important. I know of an example. Oh my goodness! So I'll be honest with you. If some child has ADHD, as a clinician,
It's very easy to see. Yeah.
this is obvious. I mean, I've one of my patients. I mean, cannot sit still in the examination room, on the table, off the table, in the trash, out of the trash, on mom's lap, coming up to me, pulling on the examination gloves.
Hmm.
I mean, through and through, right?
Hmm.
So
Problem with the Connors form, the biggest one is that it's very subjective. So it's your opinion of what the child is doing. And in a teacher's case, especially, she or he is dealing with a classroom of 30 kids, right? So it's their opinion of what the child is doing compared to how the rest of the kids are performing. Okay. So that can affect it. There is opportunity in there to direct the form in different directions if you really wanted to. Okay. The parent is comparing their child's performance to their other children. Okay. So when you look at the data on both of the forms together, sometimes it coincides, and if it's a perfect picture and you can see that the child is obviously either hyperactive or distractible in front of you as well, and it's an easy diagnosis. Most of the time, though, the data doesn't usually coincide, right?
correct.
Usually, more often than not, we see that the teacher's data will skew towards a diagnosis of ADHD. The parent's data typically won't skew towards the diagnosis of ADHD. And so these forms.
That is because the teacher is actually looking at it from her whole classroom, right?
Mhm.
She's comparing this individual to the others.
Yeah, and I mean, teachers have their own issues. We have understaffing, we have too many students, we have too much responsibility and not enough assistance. And so,
The system is broken
oh
everywhere.
yeah. So, and one of the biggest things that happens is that if your child does have a diagnosis, usually the teacher will also get more assistance in the classroom. So it makes it a little bit easier. So I've seen situations where a diagnosis is wanted simply because they can get more assistance. But the thing is, we shouldn't be allowed to have more assistance only because a child has a diagnosis. If a child just needs some extra help, they should be able to get the extra help.
100%.
But that again
100%.
is a system problem. And so in those cases, you have as a clinician, because these forms are not an MRI, they're not diagnosing something, they're giving you information that you use to make the diagnosis. So then you as a clinician look at that information, look at your patient and decide, hey, is this just normal? Is this just a 6-year-old acting like a 6-year-old? Or is this 6-year-old truly pathological and going to benefit from the medication that you're going to give them?
So again, a recurring theme that you'll notice in our podcast, every time it always comes around to patient-centered care, right?
Mm-hmm.
You have to be able to treat each one of your patients individually. So, you know, the other things that may have done an uptake in diagnosis of ADHD is, more awareness. There's, more acceptance now in society as well. So there's a lot of different reasons, but the ones that we highlighted today are the ones that we feel, in our opinion, are up there.
Mm-hmm. Yeah, I agree.
Well, thank you for joining us on yet another episode, and stay tuned for more to come.